Streeter, MD, is a child psychiatrist working at St. Luke's Children's Center for Neurobehavioral Medicine. He has broad experience with individuals, families, and symptom-based neurobehavioral issues and has a passion for transforming children suffering from mental illness. Dr. Streeter completed his general psychiatry residency at Naval Medical Center in San Diego and his child and adolescent fellowship at Tripler Army Medical Center in Honolulu. It is our understanding that Chris also has a passion for really dumb jokes or dad jokes and became a child psychiatrist so he could play with Star Wars toys and connect for it every day and get paid for it. In his non-paid time, he enjoys spending time outdoors, backpacking, skiing, and hiking with his wife and 2 sons. Today, Dr. Streeter will help us think about how to improve post-pandemic mental health for teens and adults. Welcome, Dr. Streeter.
Thank you. Thank you so much. It's great to be here. Thank you. It's really a pleasure and honor to be here with you. It's what a beautiful setting that we have, and I'm really excited to talk to you about this topic. One, just to give you some ideas about routine management of anxiety and depression, but I actually learned a lot about how COVID affects the brain, and I want to share that with you. First of all, just kind of a nod to some of our nurse practitioners out there. Claire Barton said, "The door that nobody else will go in at seems at least always to swing open widely for me." And also, thank you for allowing me to be here. I appreciate the conference inviting me and to share this, the opportunity to share this important message. So really what I want to accomplish is for you to appreciate the direct and indirect biological effects on mental health, in addition to the psychosocial and developmental sequelae of the pandemic. I also want for people to understand and apply appropriate treatments for depression commonly seen from COVID, or sequelae as well from COVID, and also inspire future learning. I think that if I've done my job right, you will go home and be like, I think that's really interesting. I want to learn more about that. Or this patient came to me with this issue. I wonder if I can figure that out. So to be more specific, I really want to give you an up-to-date sort of review of COVID-19's biological effects, not just on the brain, but also on the psychology of the person, as well as treatments of those sequelae. And kind of review some of the psychosocial and developmental considerations for teens and adults. And I think, that's really, I've got to fit that in, right? I'm a child psychiatrist. In addition to looking at how maybe some adverse childhood events and adverse community events and what we can do and how we can approach this in the future for the next pandemic. So I don't know if anyone knows the history of Psyche and Cupid, but if I have time at the end of this lecture, I definitely want to go through that. But it does I want to take an interlude before we get into this and tell you a story about Obi-Wan Kenobi and Luke Skywalker when they walked into a sushi bar. And Luke could not figure out the chopsticks. Finally, Obi-Wan says, "Use the forks, Luke, use the forks." All right, thanks for that. I'm here all night. So really, when you take a look at things, before COVID, things were not good already for mental health, especially in teens. When you look at this, really mental health challenges were the leading cause for disability and poor life outcomes in young people. And from 2009 to 2019, the decade that preceded COVID, the share of high school students that reported persistent feelings of sadness or hopelessness increased 40% to more than 1 in 3 students. In another study, about 35% of teenagers at some point during their teen years will develop depression. Suicidal behaviors increased 36%. In addition to suicidal ideation with a plan, 44%. And probably many among you can bear witness to this, having seen it in your clinics. Between 2007 and 2018, suicide rates also increased by 57% for young people. So eventually, the hospital, the CHA and the ACAP and AAP got together and published an emergency declaration that basically said the worsening crisis in child and adolescent mental health is inextricably tied to the stress brought about by COVID-19. And we'll talk about some of the the psychosocial issues that contribute to that. But the pre-COVID rates of depression and anxiety essentially doubled. As well, we saw lots of loss and grief for people who lost people during the COVID crisis, in addition to clearly increased risks of increased rates rather of non-accidental trauma. So early on, when you look at what happens to the brain with COVID, there was a lot of speculation about potential effects, but in fact, early research did not show that there was virus in the brain. That has since changed. And more recently, there's clearly spike proteins that have attached to the ACE2 receptors, which also are in the brain, the angiotensin converting enzyme receptors. And evidence of replication in the brain, some suggestion that transmission via the olfactory bulb is related to increased risk of Parkinsonism. In a recent study out of the UK, there's also some neuropsychiatric sequelae of people who are hospitalized for COVID-19 and other severe acute respiratory infections. They found that there were really no difference between that, but in fact, other researchers did find that there was a difference, especially for people who were admitted to the ICU or the floor when they were admitted for that they did correlate to increased risk of depression. So it remains an evolving body of literature. We're not quite sure exactly what the mechanisms are, but certainly there are clear effects. And in terms of these researchers actually were looking at, well, what actually happens in the brain? And they found that demyelination and neurodegeneration and actually the advent of cellular senescence actually occur with the addition of the cytokine storm that occurs because of COVID. So maybe an indirect effect, but also possibly a direct effect of COVID attaching to those supportive cells in the brain. There's also the intravascular antibody coating, which occurs, which then, of course, leads to stroke and possibly seizure. And we did see that the rates of those issues went up during the COVID crisis for people that were acutely affected. And so there's a theory that, of course, that maybe somehow those antibodies were causing microclots. And that was, of course, obviously affect someone's mental health, depending on where the loci of, or the locus of that stroke was occurring. And then as well, there's this vast, well, I say fairly vast body of literature that is actually evolving in the psychiatric community that is suggesting, or at least implicating, inflammatory responses are highly linked to more mental illness, depression, anxiety, and so on, and of course, dementia. And so there's thinking that the cytokine storm from COVID, specifically with COVID, you see large increases in IL-1B, IL-6, and multiple other interleukins and TNF alpha, interferon gamma, and so on. So there's actually a pretty big inflammatory response that occurs. And in fact, in this study, they were looking at patients who were infected with COVID, and they decided, okay, and they also had some depressive symptoms. And what they showed was that even using anti-inflammatory drugs, of these two ones in particular, that there is actually increased protection against developing depressive symptoms as a result of COVID. SSRIs and SNRIs in general remain the primary, and psychotherapy, of course, remain the mainstay of treatment to date, but we'll get a little bit more into that in a little bit. So I want to just take a second and I don't know if you ever heard the story about Chewbacca when he wanted to join a baseball team, but he was just never very good. And the coach decided it was because he was a Wookiee. So thanks for playing along. That one was for Dr. Bramwell, who, when he was with children's, dressed up like a Wookiee actually for Halloween, I'll have you know. So biologically, when you look at the treatments, as I mentioned, standard SSRIs and a few studies looked at fluvoxamine in particular, have an anti-inflammatory property, and we'll get into that a little bit here, where the sigma-1 receptor down-regulates the cytokine production, especially with sertraline, fluoxetine, escitalopram, citalopram, and fluvoxamine. And SSRIs also, of course, inhibit serotonin from binding to the G2B3A receptors in the platelets themselves, which is interesting. And that's actually the theory behind why sometimes SSRIs can cause increased risk of bleeding, especially in the elderly. But in this case, when you have a lot of antibodies floating around gumming up your arterioles, then maybe that's actually a good thing, where it could potentially prevent microvascular clotting. At least that's what these researchers thought. In addition, SSRIs compete with the kynurenine pathway to basically compete with this pathway for tryptophan, which is a precursor for serotonin. And the thinking is that maybe this is another mechanism that might downregulate the inflammatory response. In addition, SSRIs inhibit sphingomyelinase acid, which cleaves sphingomyelin into ceramide, which you may know is one of the things that COVID-19 uses to get it on or into the actual cell. So in this study, they took 95 COVID patients and treated them with SSRIs and found that 92% of them actually had improvements in their symptoms, in their post-COVID syndrome symptoms, especially the cognitive changes, which I thought was amazing. And oh, by the way, their depressive symptoms got better too, which was fascinating to me. Now, this, we all experience the psychological effects of COVID, even if we didn't experience the mental health effects or the biological effects of it. I mean, obviously, especially the younger you are, the more, sort of at risk you are to have these things impact you. And we'll get into that in terms of the developmental considerations for that. So less social support, especially when people were, at work or with COVID, maybe family members couldn't stay home. So you have younger people at home alone, separated from their primary caregivers during the day, not knowing what is going on. None of us knew how bad this was going to be. None of us knew what was going to happen to ourselves, let alone our families and let alone our patients. And just not knowing. I mean, we're not a group of people who are used to, we're not used to not knowing what's going on typically. And that's really discerning and disconcerting. Just quarantining, having survivor guilt, having substance use issues, having a child admitted was definitely a risk factor. Caring for an older adult, especially with dementia, was a risk factor for developing some depressive symptoms from COVID. And then interestingly, OC personality traits, which I guess we can extrapolate clearly if you have a desire to have things perfectionistic and clean all the time, that having an environment where there's a bunch of sick people around you is going to make you more anxious. And then also not being able to implement resiliency factors such as because of social distancing, we couldn't really spend as much time together, and then exercising, I think, was also a challenge for some people for a while. So what this led to, of course, was maladaptive coping increases, self-harm rates increased, as well as increased risk of death, overdose deaths. Substance use prevalence also was increased during this time. In addition to school readiness, educational attainment, socialization skills, all of these things, of course, are going to be affecting our younger patients, but this is in addition to the risk of social determinants of health. Also, what do we end up having to do with our kids? They were put in front of a computer a lot of times for online classes. So when already the American Academy of Pediatrics is saying, really shouldn't have your kids spend more than 2 hours in front of a screen a day, we're putting in front of a screen for 8 hours a day and then some. So negative impact on resiliency, as I previously mentioned. And so why is that? Well, I think the first aspect of this is to give you, I know everyone here knows this, but sometimes it helps to remember that the brain, in fact, is connected to the body. And here's proof. Here's another one where the brain is up there and connected to the autonomic nervous system, where we have all of these secondary effects that occur in our bodies whenever we get stressed. And that, of course, is what we track as psychiatrists to kind of see if, in fact, that downregulation of the autonomic nervous system is happening, especially with anxiety. And obviously, the limbic system is clearly linked or directly linked to this. So when we have any autonomic reaction, I don't know if anyone's ever heard of Pepez circuit before. The Pepez circuit is basically when you have any dramatic response to your environment. So your body reacts, but there's also a conscious input. And so we know this because if you saw someone holding a gun in a dark alleyway, you would go the other way. You know, you would go through that stress response where you have increased alertness, like, is that really a gun? And then maybe if you heard it go off, you'd be like, I am definitely out of here. So you would, you know, there's this spectrum of response to any stressor. Well, if we'd seen that same person holding the same thing 10,000 years ago when there were no guns, you'd be like, why is that dude holding a funny stick? You know, and so you wouldn't have the same inherent autonomic response to that input. And so basically the Pepez circuit is, you know, Pepez discovered this association where there is conscious input to our environmental inputs, but a lot of it happens unconsciously. Some of it is reflexive. So if there's a really loud noise outside the room right now, everyone's medial longitudinal fasciculus would fire and you would just look outside and be like, whoa, what was that? But that is, you know, beyond that, I feel like, you know, there's this interpretation of our environment that really affects us. And that is, in fact, what causes a lot of chronic trauma and toxic stress because of the psychological way that we interrogate our environment and then think through what the potential ways that our environment can hurt us. So we ultimately end up in derangements in the ACE-PA axis. There's downstream effects from hypercortisolemia, decreased heart rate variability eventually, decreased immunity, carbohydrate craving, substance use, sleep disturbance. All of these things lead to toxic stress. When you look at the ACEs literature, and so this is something that probably a lot of you are familiar with, but I really felt like this was a completely appropriate time to kind of talk about this. The ACEs literature is clearly showing or clearly links adverse childhood events with later on in life issues, hypertension, obesity, substance use, depression, and so forth. And it's probably through those mechanisms. I mean, I don't know that we have established definitively, but I think most people just accept that the fact that if you have chronic stress, you have hypercortisolemia, lots of adrenaline over time, all of the secondary downstream effects that you see are because of these issues. In addition to the ACEs that typically associated with, you know, the childhood experiences are community environments, and obviously COVID-19 was one of those things that threw into disarray everything. And so when you have significant number of risk factors, you can see that there's this linear association, or maybe almost exponential association, with developmental delays. And we're talking about developmental delays. Wait a minute, that's like your brain anatomy almost, right? Like this is very primitive sort of significant substrate level happenings that are going on here. In fact, what we know from this is, in fact, that you do get disrupted neurodevelopment, maybe because of environmental inputs, maybe because of attachment injury, maybe because of temperamental issues, but in fact, that the ACEs clearly do have linkage with these downstream effects, even years and years later, and also early death. And so when you look at this, you know, there's tolerable stress, and then, you know, normal stress, tolerable stress, and toxic stress. Normal stress is just everyday pressure. Tolerable stress is when we have a big event, but we can deal with it. And toxic stress, of course, is when you have chronic repeated exposures to environments that you really can't escape. And that is really what we're talking about. And we all went through that with COVID. And so it's kind of like, you know, the positive psychology literature really talks a lot about this. where that's the idea of resiliency. The very same things that get us from negative to neutral get us from neutral to positive. And that is, of course, the theory and the outcomes from that are, indicate that if you continue to work on those things, then you'll be better off in the long run. But if you don't have the opportunity, because of all of our environmental inputs that we had to put into place and so on, then it really can cause a problem. And so we've already talked about a lot of these things, but obviously any one of these things is bad for you, let alone when they all happen at once. So to bring it full circle though, what can we do? What can we do with adverse childhood events? I mean, it does feel in some ways sort of hopeless, but in fact it isn't. And what we know is that if you are stable and caring, and if people that have had multiple adverse childhood events growing up, that if you just have one person that's stable and caring, then your chances of getting through that are so much better. And so I think, and also my message to you tonight is, you can be that person, even if it is just for 5 or 10 minutes periodically. You can be that person that can be stable and caring. You don't have to be a coach or a teacher or a parent, but you can be stable and caring and model healthy coping, model that holding it, what in the attachment literature is called the holding environment for someone just long enough to give them some hope that they can get through this. And I think also as physicians, nurse practitioners, PAs, as providers and people that care for other people, I feel like that's also like one of the messages that I want to impart today, is that I feel like we can lead the people around us. We can be leaders of stable, caring people and infuse that into our society, even when they may not accept it sometimes. So one of the fourth rule, right? The house of God. I don't know if there's people that know that book, but really the fourth rule is during a code, take your own pulse first. And my first rule of a code gray or a mental health crisis is take your emotional pulse first. And I think that's super helpful, especially for people in crisis, if someone's suicidal, if someone's having issues, to take stock of how you're feeling first, which that's, of course, the classic psychiatry thing to say, right? How are you feeling about this? But if you can feel how you're feeling, if you can take a step back and observe that for just a second, it can really help you in your interactions with your patients to just kind of get a perspective on what's going on. So what do we do? The interventions and treatment for mental health sequelae are obviously the SSRIs and SNRIs for reasons that I didn't expect when I was really researching this over the last several months, that I was really shocked by the secondary, maybe downstream or additional effects that antidepressants have, or I should say SSRIs and SNRIs have on COVID sequelae. Obviously, you can think about augmentation strategies, and obviously if those things aren't working, then you can move on to more neuromodulation. But psychologically, obviously, we want to provide evidence-based therapy, CBT, acceptance commitment therapy, and mindfulness strategies have been studied specifically in this population. And it's also important if depression and anxiety do not respond to medications alone. There's several studies that have shown that STAR-D, which is a multi-center government-funded study, in addition to the treatment of resistant depression in adolescent study, also multi-center, government-funded, that determined or basically showed that you have to do therapy if the medications really aren't working. And especially if you've tried and failed multiple, like 3 or 4 different SSRIs or SNRIs. You really have to think hard and advocate for your patients to do therapy. In addition, a lot of times these things kind of get maybe thrown under the rug a little bit, but pro-social behaviors and communities are clearly helpful. Do the best you can to bolster resiliency factors and work to minimize social determinants of care, because these things, again, are linked to poor outcomes. So just to get to the nitty gritty, Fluvoxamine was the one, from what I read anyway, it seemed to be the most studied, and that's definitely not something that I reach for firsthand. Fluvoxamine, however, is well accepted, especially to be helpful with anxiety, but also works with depression. And these are just my recommendations to start with this. And typically, anytime you start an SSRI or SNRI, usually, having someone follow up in 4 to 6 weeks is really helpful. That's the point at which you reach between 60 and 70% of response at that dose. And so that's kind of guides the follow-up schedule for that. If you do get to higher doses, you want to look at BID dosing, especially for fluvoxamine because of its shorter half-life and potential risk for serotonin discontinuation symptoms, which of course are very uncomfortable and may cause your patient to not want to take that medication anymore. Sertraline has a half-life of 26 hours, so that's a little bit better. You can get by with daily dosing there. And fluoxetine, of course, has a half-life of 96 hours, even at when you've been on it for a while. So this is usually what I do. In teenagers, I will kind of max out at 60. I have gone to 80 a couple of times, but only if it's well tolerated. And the same is true with adults. I'm happy to talk more about that if I have time. How am I doing on time, by the way? That halfway there. Thanks. So in this study, this is interesting. This is again treatment of 95 post-COVID patients. What they found here was that the doses of SSRI were typically lower than what you normally need for anxiety. And we do know that for anxiety, both in teens and adults, especially for OCD and panic disorder, you're going to really need to drive up the dose of medication. Again, I can talk more to that if you need me to. But for instance, let's just say fluoxetine. Typically for fluoxetine or Prozac, you need to get to 40 or 60 milligrams to really knock out a lot of anxiety symptoms. And probably if you've done a lot of mental health treatment, you'll have had many patients probably who respond to lower doses of SSRI for their depressive symptoms. And then they come in a couple of months later and say, hey, I'm still really feeling anxious. And that's not uncommon. And so the good news is I tell my patients, we don't have to do a different medication. We'll just go up on the same one. 90% of people in this study actually responded to these interventions and had some improvement, at least, with 63% reporting better than moderate improvement, which for me is amazing because the number needed to treat normally with antidepressants for depression and anxiety is 3 to 6. And so that's pretty remarkable. Of course, this is the major limitation of this study was that there was no control group. But even if some of this was placebo, hey, I'll take it. So, oops, okay, good. So from both child and adult studies, if anxiety is comorbid, as I just mentioned, we're looking at higher doses. I would consider a failure of a medication when you get to at least 50%. This is well defined in the literature as an adequate an adequate trial. If you get to 50% of the medication, FDA maximum, for 6 weeks. And so typically a response is generally accepted to be 30% reduction in symptoms. So by that logic, if you have someone come in, you're 50% of a medication, you have 30% reduction, well, is doubling it going to get us 100%? Maybe not. And of course, with depression, 100% resolution of symptoms is the goal. With anxiety, sometimes I'm happy if I can get someone's OCD symptoms, knocked out 75%. I feel like that's a win. But with depression, definitely 100%. Symptoms are gone. That's the goal. And you do want to counsel people on signs and symptoms of serotonin toxicity and also discontinuation symptoms when you're doing a cross titration. But I can give you more specifics on that too. Basically, I just come down on one gradually over a week or two, depending on the dose we're starting at. If you're starting at 200 milligrams of Zoloft or sertraline rather, and you want to get on to 20 of fluoxetine, I don't usually go from 200 of sertraline to 60 of fluoxetine. And when I switch medications, I'm hopeful that, of course, the lower dose of that medication is going to be helpful. So what we'll do is just come down. So I might go to 100 milligrams or even 150 milligrams for a few days of sertraline when I start fluoxetine, and maybe just 10 milligrams. Do that for a few days, keep the fluoxetine at 10 milligrams, maybe for another few days as I come down on the sertraline, and maybe go up to 20 milligrams of fluoxetine as I continue the taper of sertraline. So that's the basic idea. I could count on one hand the number of times that's actually not worked out. So that generally does work out, at least in my experience, most of the time. So in summary, COVID was and is bad. It's bad for the brain, it's bad for our society, it's bad for our psychological health, but it's also, it's bad. So if you take away anything from this, remember that. And it's, the prevalence of depression in adults actually increased, tripled. It tripled when compared to pre-pandemic levels. So it was bad for adults too. And there's evidence that persistence in depression and anxiety symptoms, especially with sleep, months later when compared to non-COVID depression and anxiety is a factor there. So, and how bad is it? It's about as bad as war. And this is from a study from a British BMJ study on military health, where they followed people, and about 38% of them in their cohort had some mental health issue, whether that was anxiety, depression, substance use. And from the big studies that were done by Hoag et al., which probably everyone, well, maybe everyone is familiar with, but these are from 20 years ago, right? Where combat veterans typically had a significant increase in anxiety, PTSD, depression, substance use. And later studies would approximate if you went to war, you had about 20% chance of coming back depressed. So I just want to shout out to all of the veterans out there who are still standing the watch so that we don't have to. I don't know, are there any veterans in the audience? Thank you. Thank you for your service. Appreciate it. So what we know is that COVID, and when you add in youth, even all the way to 40, is even more bad. From this study, the prevalence of anxiety, the risk of developing anxiety is much higher the younger you are. So why is that? I mean, it's still not good for the older folks, but it's why? Well, when you're a hammer, all the world's a nail, right? So as a child psychiatrist, that's how I look at the world, is developmentally. I love this quote by Erickson: the more you know yourself, the more patience you have for what you see in others. So Erickson kind of broke it down for us. He put together this theory of development. Really, the first main theorists, or psychiatry, psychology theorists, to talk about development through the lifestyle. Up until that point, everyone was like, well, when you turn an adult, you're done. You're just essentially the same. But no, he identified that clearly there are phases that we go through in our lives. And so what I want to focus on here are the virtues. So basically, when you're born under 2, you can't take care of yourself, so you require someone else to. And when you have a wet diaper, it's like the end of the world. And then you cry and someone comes and takes care of you. And then when you get hungry, you cry and someone takes care of you. We were just talking about this earlier. But if you have people that basically take care of you, you eventually realize that you're going to be okay, and you establish a basic sense of hope in the world. And then when you decide that you can poop and pee where you want, and you can move where you want, you start to explore the world, and you have this sense of will. And that's whenever, that's any parent can painfully remember that stage. But that then, if you can do something with yourself, you decide that you have a sense of purpose. Like, I want to go outside, I want to do this, I want to do that. And then once you start doing things, you're like, I want to be good at this. I want to be the best baseball player. I want to be the best cellist, or I want to be the best skier, or whatever it is. and you start to compete with other people. And then eventually you decide that you have a basic sense of competence in at least something, whether that's your grades or whatever, your sport. And what that does is it sets you up for a basic anchor point around which to swivel and develop a basic sense of identity. And so as you learn more and more about yourself in your teen years, you develop a basic sense of fidelity and integral aspect of, like, you kind of know who you are. But really, the 20s is the critical decade of life that people really develop their authenticity, and they really develop who they are as a person. And then once you know who you are, you can engage with other people on a more authentic level. You're not so concerned about what they think of you anymore. And then what that lets you do is it lets you care for other people in a more meaningful and profound way, and so on and so on. So that, when you look at things developmentally, not just, developmental screening, what I mean here is not just doing, the ages and stages. What I mean is really figuring out where your patient is psychosocially. Where are they at? And I think when we all have a big trauma like COVID, it takes us all back to zero, where we're like, I don't know, am I going to be okay? If I go to work, am I going to get sick and die? And in fact, that has happened. And I wouldn't be surprised if any of you knew someone who you worked with that passed away because of that. And so, asking those questions about where people are at psychologically, I think, is critical. It's not just helpful in terms of caring, but it's also helpful to get a developmental sense of where someone is. Figuring out if there's support at the school, and deeply inquiring into social functioning. For instance, I always ask my kids, who do you sit with at lunch? And that's just an example of one question that helps give you more information about what's happening for someone in their lives. So, as I mentioned, the younger you are, you have all of these issues of hope, will, and competence that may come back, but then your basic identity and fidelity as a teen, and intimacy and love concerns as a young adult. And then for the older people, caring and identity, meaning, and identity and meaning as a parent is a big one, because that, for any parent, COVID was a huge impact. Anything that gets in the way of your child's development, you're going to be like, what can I do? It's going to be an obsessive thing naturally for someone who is in that phase of life. So anyway, you get the point. So I think, during the next pandemic, we do know now that telehealth is at least not inferior to in-person psychotherapy. So if that's all you can do it. And that it does work. Also, remember to take your own pulse periodically and be stable and caring. And I think that's true. I mean, that's true for all of us, but it's especially true, I think, how can we come together as a society, as a medical society, and help our communities be also stable and caring? So, does anyone have any questions? Yes, sir.
There was a big controversy early in the pandemic, grew it, about whether masking had any effect on kids. What do we know about that?
Well, that is a great question. So the question is, did masking have any negative effect on kids? And yes and no. What we know is that it did interfere with their ability to communicate. Especially kids with autism seem to struggle with that a little bit more. And I think that my approach to that has been throughout this process that we need to find a way to help kids work through that. We need to demonstrate healthy ways to communicate, and especially non-verbally, which of course kids with autism do have that struggle, non-verbal communication, but we need to demonstrate healthy coping with our masks on to help them work through that process. I guess that's, yeah, I don't know if that answers your question, but I think there is some evidence that it was deleterious in terms of their ability to socialize and so forth. But I also don't know if in all of those environments there were examples of healthy coping. So, yeah, next question. Go ahead.
Your thoughts on psychological safety? During the pandemic, a lot of us felt unsafe.
Yeah.
Even if we didn't get COVID, we felt unsafe in more health. I mean, how do we support that? People, if they do feel safe in an unsafe situation.
Yeah, great question. The question is, how do we support psychological safety when none of us feel safe? And I think, I mean, I don't know that there's a good answer to this, but my approach to it was to give people the freedom to feel unsafe and honor that, and basically say, look, if you don't feel safe to come into work, I got to respect that. I mean, I'm coming into work, but that's just me. And I feel like that's just my role here. You know, I'm going to take that risk. There's people that are depending on me. And so that's what I'm going to do. And just trying to know as much as possible. You know, as human beings, we're always trying to tell stories about things and trying to know as much as possible as we can, but still, I guess, being comfortable with the ambiguity of potentially that it's not. And I guess just continue to be stable and caring and trying to promote that, but also respectful when people weren't feeling safe. And not to shame anyone. I guess that's the biggest thing is, I don't know if that answers your question, but that's a very, very good question. I don't know that there's probably, maybe everyone has an opinion on that one. But I think, you know, promoting resiliency factors, trying as much as possible to, again, model healthy coping, and stay away from maladaptive coping as much as possible, and continuing to maintain an open dialogue with people is really the only way that I know how to support that. Yeah, and then back there was a question. Oh, right by the window, yeah. Sorry, we'll get to you next.
My question is with regard to the different stages. Is there a belief that people arrest at that stage, and can they move past that stage, or do they have to kind of go almost backwards and work through that so they can move forward?
Yeah. Oh my gosh. Thank you. Wow. I could talk for another hour on that. That's a great question. So yes, people do arrest at those developmental stages, but typically, you know, for instance, there's a lot of thinking about, you know, the cluster B personality disorders as having trauma or some sort of developmental arrest between 1 and 3, when some of those critical stages don't occur. And I only talk to the psychosocial developmental stages, but really, for instance, Margaret Mahler talked a lot about rapprochement. I don't know if that's maybe ringing a bell from back in med school, but or your training. But the idea is that during that phase of life, you integrate both positive and negative aspects. So, you know, you want to go outside, but your mom is like, no, I'm not going to let you run out into the street. It's not fair. And then you're mad at your mom. But then you love your mom because they do everything for you. And then it's sort of like, oh, I don't know what to do. You know, and that's the idea of rapprochement, is that you integrate those positive and negative emotions towards someone and somehow tolerate, as I just mentioned, ambiguity. And then people that can't do that end up, you know, a lot of times struggling with narcissism, or really more commonly probably borderline factors. And so, yes, there's clearly, I guess, at least in the psychology and psychiatry communities, we feel that people can arrest at a certain stage, but that people can also regress and really struggle with getting back out of that. And so that's why I feel like the developmental approach is critical, so that you can then go back in time and figure out where someone is internally and then work with them to get them to the next step. Erickson actually himself said, these are not stages that we accomplish. That I think is a common misconception. And he, in fact, says this in his book, Identity and the Life Cycle, that it's a common misconception that we just attain these things and that we're good. as soon as we are, fully functioning, caring adults, that we are good. No, it can always, we can always go back and have questions of, am I going to be okay? Are my kids going to be okay? And that just takes, pulls the rug out from underneath you and really takes your sense of trust in the world away, which is 0 to 1, right? It's a very primitive kind of place to be. Anyone who's experienced significant trauma can tell you that it's usually unexpected, and that's a big part of it. Like when is the next foot going to fall? So anyway, but yes, thank you for that question. I think it's the critical piece is going back and figuring out where someone is, so that then you can then kind of jump ahead, because you can't talk to someone who's really struggling with their safety and be talking about, competence issues. It's like, we got to deal with the safety issues right now. We've got to make you feel safe again and feel like there's hope that you're going to be okay. Otherwise, we're just, that's like, I guess, psychological first aid, right? And sort of like establish safety first. Yes.
If you're trying to treat some people and they're failing with a couple of therapies, do you do gene psych testing? Do you like that? Any comments on gene psych testing?
Sure. Yeah, I would love to comment on that. It's a great question. I guess, should I repeat that one? Okay. So the question is, what are my thoughts on gene site testing? Any pharmacogenomic testing is going to give you potentially some very valuable data. It also can be misleading. And so when you look at pharmacogenomic testing, it's basically just how your body is processing that medication. It can tell you whether or not the medication is poorly metabolized, so it's going to increase in the plasma, and therefore be more likely, theoretically, more likely to cause negative side effects and therefore discontinuation. And as we all know, medications don't work if you don't take them. Or alternatively, if you're such a rapid metabolizer for a medication that it never gets to a therapeutic level in your system to begin with. That being said, it's interesting, the normal half-life of atomoxetine, for instance, a treatment for ADHD, is only 5.4 hours. And you're gonna be like, what? What is that? I mean, it builds up in your system over 3 to 4 weeks, but by the time you take it the next day, it is essentially 5 half-lives gone, out of your system. And so it's because the effects of that medication are on the norepinephrine reuptake inhibitor, on the norepinephrine reuptake system. And so the theory is that it builds gradually over time, just like the SSRIs and SNRIs. I do think it can be useful for people who have had multiple weird, like atypical, reactions to SSRIs or SNR or any psychotropic medication. I will get it in those circumstances. But if I've tried, 2 or 3 SSRIs and then I move on to an SNRI or bupropion, if I'm managing depression in that case, then yeah, if I start running out of room or runway, I'm like, okay, maybe I should get that to see if there's anything strange in there that will give me some insights. But maybe all of the medications are rapidly metabolized, which I've had a couple of times. And then I'm like, wow, I gotta really crank this up. And I know I'm probably going to try fluoxetine again because it already has a long half-life of several days. So I do think it has some utility, but you have to be careful. I definitely don't get it, even for patients where I've had 2 or 3 failures. But, yeah, thanks for that question. Did I answer your question completely? Okay. Yeah.
Mental health is progressively getting worse in kids and teens prior to the pandemic. It really accelerated during the pandemic.
It did.
Post-pandemic, has there been any correction back? Has it been improvement, or are we just even further beyond that work?
Yeah.
And then the second question is do you have any recommendations on how any programs or things that we as physicians or community leaders or church leaders utilize to help improve resiliency in young individuals?
positive psychology.
Yes.
there's Nurturement, so there's different theories behind it. I'd just like to hear your opinion on this.
Yeah, thank you so much. So the first question, has it corrected, have the prevalence rates of anxiety and depression, teens, adults corrected? I don't know. I didn't read any studies about that, to be honest with you. I would say anecdotally, I feel like things have, I'm not gonna use the Q word, but things have slowed down. At least the referral rates for our clinic have, gone back to a more normal level, I guess, a pre-pandemic level. But that's just one clinic. I don't have any good data for you anywhere. That's a great question, though. The second question, what can we do to promote resiliency? That, I think, at least in the schools, having peer supports like Hope Squads or Sources of Strength do have pretty good evidence that those can be helpful. So promoting mental health support in the schools. And in terms of probably just doing everything that we already do, with our patients, lay off the sauce, do what you can to exercise. Aerobic exercise actually is better than other forms of exercise, at least from a mental health perspective. And that in those studies, they looked at group exercise, but also aerobic exercise for 30 minutes, 3 times a week or more. But yes, establishing community supports, better communication, promoting family relationships. If there are, especially in kids, I feel like if there are kids that are isolated, to find ways, I talk to a lot of parents about finding ways to promote the tribe, so to speak, where if kids are isolated because they're online schooling or whatever, to try to find a church group or, Boy Scouts, Girl Scouts, maybe even, if they're having gender concerns, PFLAG or some other agency that, not necessarily I don't recommend it, but I say you might want to look at these things and then interview them, like seek out the support and really investigate it and interview them. And if you feel like it's a good fit for you, then maybe continue with that. But I talked to a lot of parents about talking to their friends and try to support their kids with their friends' kids, or at least vet other parents to find kids that they can develop really chummy, BFF relationships with. And that is absolutely critical, I feel like, especially as you get older, you want your kids to be more and more independent and not more dependent on you as a parent. And so promoting those, pro-social behaviors and independence in healthy ways, it can be really helpful. And that oftentimes means a lot of energy, time, and money, and you got to go to jump time, or I guess it's a trampoline park or something. Those things are expensive, and so, but I mean, if you can invite along 3 or 4 other kids and kind of observe them while they're interacting together and be like, well, that kid's not coming next time because they just slapped my daughter, or, whatever it is. Like if you see other kids, promote that and be like, hey, we need to ask these 2 kids out the next time for jump time or ice cream or something, because they're solid, stable, caring kids. And so, but yeah, I think, there are systemic things that we can do and to promote that in the schools. And if you ever have a question on that in the future, I'd be happy to speak to that. If there's a community leader that you would want me or one of our other, subject matter experts to talk to, I'd be happy to. Yeah.
You find that screen time now that, it's post-COVID now, of course, and schools have maintained the computer use. Kids are on, social media, they're, learning more about body image. I'm seeing more anorexic children.
Yes.
I'm seeing more children with anxiety and depression because they're not living up to what they're seeing or what people are saying. Because when they're behind the screen, they can say whatever they want.
Right.
The one-to-one interaction, and they're losing their social skills because they're, on other kinds of media versus that one-to-one type interaction. And I live in a rural area where there's a lot of latchkey kids.
Yes.
So just wondering how you're kind of engaging those kids without sometimes the parents really being engaged.
That's a great question. The question is, how do we engage parents and kids and help them develop, maintain a normal developmental trajectory, especially with the extra screen time that they're exposed to, and continue despite the pandemic having quieted down. Oh, I said that Q word, sorry. But anyway, that's a great question. I think that's especially when I want to talk to parents about, getting out, doing things with other kids. If they're teenagers, going to the movies together and you just sit a couple rows behind them and they can do their thing or that sort of thing. I feel, well, there's that old saying, comparison is the thief of joy, right? And in fact, we talked about maybe doing a lecture on today, this lecture being instead the effects of social media on mental health. And I think, it's that literature also is evolving. It takes, 10 years for literature to actually get into practice as on average or something ridiculous like that. So we should be seeing, and we are seeing some compelling studies that are looking at that. Functional neurological disorders is another thing that we see as a result of social media. Lots of kids coming in for tics that aren't really tics. They're just they're behaving in that way to. And really, what does that speak to? Why do we have increased rates of anorexia? Is it because of the comparison? Because that our kids are trying to compare themselves to other kids that are these social media stars and influencers and making, 6 figures and 7 figures every year. I can't tell you how many times I've had kids come in and be like, I want to be a YouTuber, an Instagram star, or whatever. What does that speak to? To me, again, as a developmental psychiatrist, I feel like that speaks to either an arrest or a regression in development. And so, it's, I think it's incumbent upon us to help families get back on track. And so wherever that is, if it is more outside time, if it is more time with friends or family time, or with other groups, that really just kind of reestablishing that and having some more balance. So. Yeah. That is hard. And I think really, again, you're talking about social determinants of care, and it's more social interventions that we need to try to at least promote when there's really no blood in the turnip. That's a real challenge. I think, again, just it sort of feels hopeless, right? And that's, again, where I feel like taking your own pulse, taking your own emotional pulse, it does feel hopeless. And it's sort of like, well, wait a minute. If I'm feeling hopeless, how does this mom feel? And if mom is feeling hopeless, how does the kid feel? And so being a voice of hope, even if it is hopeless, I think even though that sounds schmaltzy, but I got to tell you, I think that's the more therapeutic thing than anything for a lot of times whenever people are really struggling. It's just being like, you know what, I've been doing this 20 years and I've never worked with someone that doesn't get at least a little bit better. So we're going to be in this together and we're going to figure it out. I don't know what the answer is right now, but we'll work on it. And that's, I think, when you come alongside someone, and I learned this when I was in Afghanistan, actually, where people have had terrible, terrible traumas that then there is no chance that they will ever fully get over that. But just walking up alongside them, emotionally walking up alongside them, feeling what they're feeling, and standing with them at the edge of the abyss is probably, the less I tried to fix things, the better I feel like people got. Paradoxically, sometimes. Don't quote me on that. But yeah, there are definitely things you can do psychiatrically and psychologically that can be helpful, and socially maybe sometimes. But I think when all hope feels lost, it's not.
Thank you, Dr. Streeter. We really appreciate your response.
Yeah, my pleasure. Thank you.